On Beyond the OR, Dr. B will take you beyond plastic surgery. Listen as he talks with doctors, friends, people who have inspired him along the way, and patients whose lives he's changed. With your host, Dr. Kevin Brenner.
Welcome back to Beyond the OR, and today I'm really excited to have one of my favorite colleagues in studio with us, Dr. Shirin Towfigh. Shirin is in practice across the street from my office.
Literally.
And literally across the street. Literally, I can throw a rock and probably hit her office. She is a hernia specialist and has the Beverly Hills Hernia Center in the building across the street, and is a super specialist in all things hernia, and including removing hernia mesh when people get sick from it. So we're going to get into that, and we're going to get into her background and what's new on the scene in hernia surgery. So welcome.
Thank you,
Dr.
Kevin.
Towfigh. Nice
Very
to have you.
Elizabeth. Thank you.
Nice to meet you. I'm excited to have a fellow strong woman doctor, a leading woman doctor.
Thank you.
Who specializes in hernia. I read so much about you and I'm really excited.
Hernias are a very sexy topic, not like plastic surgery.
Well, you know, it's not all glamour, as you know, right?
Sure.
Plastic surgery is not glamour either.
I mean, maybe more than hernia surgery.
Still not that glamour.
We still make people's lives better.
Yeah, the difference is that no one talks about their plastic surgery, right? Everyone's like, I got a hernia repair.
Do they? Like
Yeah.
at the dinner table? I'm not so sure.
Well, we did it growing up in my house. We talked about everything. Nothing was off limits.
Fair.
So welcome. So for our viewers, well, first off, I was on your Facebook Live last year,
Yes.
which was really cool, which I really enjoyed very much. And so thank you for returning the favor. And we've known each other in practice for many years and lots of patients in common. But as my breast implant illness practice has exploded, it was of super interest to me that you were dealing with the similar thing with patients with hernia mesh. So same kind of immune response, ostensibly, to hernia mesh, and because you're probably the only general surgeon that I know that is even talking about it.
Yeah. Yeah, and I reached out to you.
Yeah.
Because you were talking about breast implant illness, and it's a very important topic. I feel like your community has done a good job of addressing it. There's a name for it, BII. And in my community of the hernia surgeons, there's a lot of denial that, in fact, we used to be told that mesh is benign. I used to even use that term. It's benign.
I was told the same thing. I mean, I did general surgery residency and was told the same thing. I put in
innocuous
mesh left and right.
Yeah, and that's not true. Now, most patients do fine with their hernia meshes.
Right.
But
most patients do fine with breast implants, but the ones that don't are really sick.
So the U.S. standard of care is to use mesh for almost all hernias, almost all. And so there's a question of maybe that standard, which is based on evidence and prospective randomized clinical trials, whether we are actually over-treating a lot of hernias and therefore overusing mesh. I'm not going to say misusing mesh because we know the evidence shows it's a better treatment option, but a lot of people are hurt because the mesh does inflict an inflammatory response, and in some patients that inflammatory response is intolerable and just really affects their quality of life.
What are some of the side effects of, like, if somebody has an allergic reaction or a reaction to the mesh, what are some of those symptoms?
Yeah, so that's a work in progress. We don't really know exactly who will get these problems and what exactly is a diagnostic kind of symptom. But what we notice is a patient's totally healthy usually. They get their hernia repair with mesh, and then within days to weeks, maybe a year, they will start feeling chronic fatigue, brain fog, memory loss, difficulty sleeping.
Sound familiar?
Yes.
And then head to toe, hair loss, visual changes, ringing in the ear, joint pains, weird tingling in the fingers and toes, bloating, intolerance of certain foods. They start getting weird rashes all over their body. Then you take out the mesh after making sure there's no other reason why they have those symptoms, and they're like a new person. They're back to normal again.
It's exactly
This
like
is
BII.
what I say every day. Now, a couple things. First of all, viewers may have missed it, but I didn't miss it. You said it's standard of care that it's a better operation to use mesh when you're fixing a hernia.
Correct.
First of all, let me just tell the viewers what a hernia is actually when one organ goes through another. The hernias that we're talking about most commonly are of the abdominal wall or in the groin, right?
Yeah.
These are the ones. Those are the most common ones, like inguinal hernia, ventral hernia, umbilical hernia.
Correct.
Those
Most
sorts of
common is groin hernias, what we call inguinal, or like abdominal wall, belly button, and other areas of the abdominal wall.
And when you say better operation or more effective, we're talking about recurrence of the hernias. It's a lower recurrence rate with mesh.
Purely looking at recurrence, mesh always wins over non-mesh.
Right.
Correct.
I agree, and that's what I was taught, and I agree with that.
It's a fact.
But
yeah.
But
Well, layman, I'm not a doctor, so is mesh the only way you can fix a hernia?
No. So there was a time when we didn't have mesh. There are all these other options. Plastic surgeons are actually very good at non-mesh repairs for the abdominal wall. That's kind of like your world.
right.
In general surgery, we're not exposed as much to the plastic surgery way of doing hernia repairs. And mesh has become a very quick, easy, relatively low risk way, good recovery to do hernia repairs. And so they always look to studies. Okay, we'll take half the patients, we'll mesh in half and no mesh in the other half. And the people that got mesh always had better outcomes in that their hernia did not recur. And no one really looked at all the other potential side effects of mesh: infection, pain, and then this whole concept of an illness against it. Yeah.
And the other thing that you said that kind of struck me, you said our community has done a good job of making awareness of breast implant illness. That's not actually true. I have, and there's a group of surgeons that have, but breast implant illness was actually a patient-generated name and
That's
phenomenon on social media, online and stuff. There's as much, if not more, resistance to that in the plastic surgery community, both from corporations, from the government, and from plastic surgeons, than there probably is with hernia mesh. And I think there's no
We're horrible.
No resistance.
So at least you have a term, breast implant illness.
Right.
I just published a paper for the first time using the term mesh implant illness, never been used before. At least you have some papers that actually addressed it. Now they looked at it and said it doesn't exist.
Well,
many
we do.
times.
Well, that's changing.
But we have
now.
zero papers.
Yeah.
I'm one of the few that's actually like saying, here's my patients, here's what's happening to them. It's zero. It's not even like, I know yours is maybe greater than zero. Mine's like zero.
Yeah, I mean, it's starting to come out, and I think it's just the tide has shifted, and there's so much talk about it that our societies are no longer able to ignore it, and they're addressing it and they're studying it as they should. Now, we can argue whether or not the studies that are being done or have been done are powerful enough or good enough studies to be statistically significant. There's also a lot of conflict of interest. I mean, and the issue underlying all of this is similar for mesh as it is for breast implants in that it's big money. I mean, like these companies that without naming any names of corporations who make breast implants or hernia mesh, there's a lot of mesh and a lot of breast implants that go in people every year, and it's big money for these companies. And so if that suddenly turned off, not that it's going to, but if that suddenly turned off, that's a lot of ad dollars. That's a lot of money, both to companies and to societies. I mean, our societies, a lot of our meetings are funded by breast implant companies.
Same, yeah.
So it's there's the whole issue of conflict of interest in terms of doctors, whether intentionally or otherwise, getting either money or I mean it's not really a kickback, but funding for research or this, that, and the other,
Yeah.
or just being paid to spokespeople for hernia mesh or
Correct.
breast implants. Yeah.
So you're absolutely right. I would like to say, similar to the breasts, for the mesh, it's been very much patient-driven. And the patients are crying foul and saying, like, why am I sick? And this is not cool. And the problem is they go to a lot of doctors, and we don't know yet. We need to have a certain, like, critical mass of patients to complain about these things to learn from it. So if you look at a population, millions of patients, and like 0.1% or 0.5% or some small number has this very dramatic response to these implants. As a population study, you're never going to catch those patients. But like your practice or my practice, we specifically see those patients. So in my practice, I think 10% or 11% of my patients come specifically for this problem. It's what I do. So I'm seeing a very broad portion of a very small subset of patients. So that gives me insight into being able to rattle off all these different symptoms they have because it's patient after patient after patient. The problem is when you look at evidence-based studies, it's a population study and it never reflects what's going on with the individual patient.
So that brings up a good point, and this is the conversation. Elizabeth was one of my BII patients. That's how we initially met.
I was
Oh, so
really
did you
sick.
what I
Oh,
was
yes.
saying?
Relate. I lived
Ding, ding, ding.
through it.
Yes,
Yeah.
So it always in the back of my mind, and I'm curious what you do. Like, what do you say to your patients when they come in for your consultation and they tell you their symptoms and you're like, holy crap, this person has mesh illness, right? Or breast implant illness. Like, sometimes, I actually started collecting symptom data and severity and stuff about a year and a half ago.
You have a form. I've seen your form.
Yeah. So they're kind of on alert when they come in before they even come in the office. But like, it always comes down to, I'll see the patient, I'll hear their story, I'll read through their paperwork, I'll examine them, and then it's like, okay, what did we do? And then at some point I have to be like, look, I take out your implants, nothing may change.
Correct.
Like, because I can't guarantee to anyone, and I tell everybody the same thing, nothing's going to change, but you'll probably be better. And that's a huge leap of faith. With breast implants, you can go back. It's not that it's that easy, but you can go back and put in another pair if it turns out that we're wrong, right? You can always go back and put them in. With hernia mesh, it's a little bit more complicated than that.
Right, and I'm very honest with them. I have a special interest in learning about this process, so I tell them we're like in the middle or the early stages of learning about this. There's no objective blood test I can say, like diabetes. Yes, you've got diabetes. I can't say, here's your blood test. Yes, you have mesh implant illness.
Right.
But if a guy comes in my office, I'll say, we tend to see it more likely in women. We tend to see it in younger patients. We tend to see it in people that have a lot of autoimmune disorders themselves or in their family or allergies. You don't fit that profile. So I think mesh should be okay for you. I can't guarantee it.
You're talking about putting it in for the first time.
Yes, and then when they come to see me, now they're having symptoms, let's say,
Right.
I'll say, again, you don't fit the profile or you do fit the profile, but I'm not going to do this enormous redo operation that has its own risks if it's not going to help you. So let's make sure you don't have lupus or rheumatoid arthritis or
MS
some actually medical disease that can be treated that mimics mesh implant illness. And I've had a couple patients where they actually ended up, one patient actually had ulcerative colitis. So I diagnosed him with ulcerative colitis, he got treated. So most of his symptoms went away. But he still had a little bit, and probably it was, he had unknown inflammatory bowel disease. He got mesh in him. The unknown disease got worse with the mesh. Treated the first disease, but the second disease was still there, so I took out his mesh, and he's fine now.
Right, and critics would say, well, see, there's nothing there. He had ulcerative colitis.
Yeah.
The mesh didn't cause the ulcerative colitis, but did it make it more severe?
Correct.
Did it impair that particular individual's ability to mount an immune response to the ulcerative colitis. I mean, I just the other day had a deposition. I'm an expert on a breast implant illness case, which was super interesting to me, and the interesting thing is that, you know, trying to explain to an attorney or anyone who doesn't take care of these patients, like, what it is. Well, you know, this patient, she's better, she's 80% better, but she still has this X, Y, and Z symptom. I'm like, but she's 80% better.
Yeah, and she was fine before.
And that's a hard thing to get across to some
Correct.
people.
There's no certainty in what we do in medicine in general, and this is one of those diseases where we just don't know enough. And so it's in law, it's very difficult to try and support something where you can't say exactly like yes or no. It's always like yes, kind of. But you know, from a patient standpoint, the good news is there are people like you or me that are legitimate doctors, that are voice of reason. So when I go and give talks now, I give talks at the meetings. So I'm a reputable surgeon. I'm not like a quack.
Right.
And I'm you know, well respected within my peers, and now I'm talking about this, and now it's giving some legitimacy to the process. And I'm seeing, you know, in our forums, doctors are talking about it now. Could this be it? They're not telling the patient they're crazy anymore. I feel that more and more, at least they're open to understanding that there is this illness and it may be the problem with their patient.
Well, I got to say, as a patient and not a doctor, it's kind of amazing to find doctors like you and Dr. Brenner, because a lot of doctors will be like, well, there's no diagnosis for that. It's not a medical diagnosis.
Right.
So then you're, as a patient, you feel like, I'm not being heard, I'm not being seen, I know my body, you know, and when they don't know what's going on, they just say, oh, you have an autoimmune disease, but they can't tell you what it is. Or so it's doctors like you guys that are on the forefront, even with resistance by sometimes the medical community itself, but you guys are out there changing and talking about it and listening to your patients, which I think is key. And not only that, but you also, you're an author, you've written books in medical journals, you speak, you mentor. Tell us a little bit more about that part of your job.
You want me to talk about myself?
Yeah, absolutely.
That's why I'm here.
Thank you. I want to just make a comment about that.
That's so easy.
Is that right? Is that doctors are humans just like everyone else. We just happen to have a different education. So as humans, there are those that are very afraid of uncertainty, or they're just not inquisitive, you know? And there are others that are constantly craving to learn more or be a detective. You know, some people are detectives, others are not. So like Kevin and I feel we're like detectives. Oh, let's see, let's figure this out. And we're okay getting thrown a curveball because we're going to try and figure it out. Other doctors, that's just not their personalities. They're like, not my problem, it's not my mesh, everything's fine. And so just, I hope patients appreciate that it's not like your doctor is a bad doctor, it's just that their personality is one that's not going to be able to help you because they like to do their procedure and move on. And some of us are okay being thrown, you know, questions and uncertainty and try and work in that arena. So,
and that's
I'm
the
glad
kind of
you
doctors.
got to see Dr. Brenner, because your life sounds like has changed.
Completely. I couldn't even walk.
Oh, wow.
My feet would have burned, they would burn at the bottom. I couldn't open jars. I had weird rashes. They tested me for Hashimoto's. I got acute pancreatitis. I hadn't had a normal lipase in almost 3 years. And as soon as I had my implants, we even did the surgery with my lipase elevated because I was like, I don't care. I know it's that. I know it's that. And Dr. Brenner's like, I can't guarantee. And so we...
How many times have you been back to the emergency room since you had your...
0.
How many times were you in the emergency room before you had your explant for abdominal pain?
I was 5 times I went to the emergency room for acute pancreatitis. They couldn't figure it out. 3 months after I have the implants removed, I surprised Dr. Brenner. I go, look at my lipase, normal.
What?
First.
Okay, that's
normal.
interesting. I haven't seen that one. Yeah.
Neither had I.
But we're learning. We're constantly learning.
And so, is it a coincidence? Is it a placebo effect? Everyone, that's what I mean.
No.
You don't know, but you just put that in the box, and you just keep moving
I
forward
know.
until you figure it out.
I might not have a medical term, but I know.
But now, if I have a patient with a lipase and I strongly feel that they have maybe a mesh implant illness because of everything else going on, I mean, I learned something new today.
Why did you pick hernia? Like, why did you always know you wanted to be a doctor?
Never.
And
Doctor, yes. Hernia,
Why did you pick surgery? Let's start with that. I mean, it's like
what led you down that road?
I like to be tortured.
I don't know that I would have done that again. Where did you do your surgery residency? I forget.
UCLA.
And then beyond that, did you do a special hernia fellowship?
No.
You just did it on your own.
Yeah. So I went to medical school at UC San Diego. The surgery department there is considered to be a very malignant program.
It is. I interviewed there.
Yeah. It was scary. And I definitely didn't know that surgeons were doctors, actually. That's how little I knew about surgery. I just didn't consider surgeons doctors. I thought internal medicine was the way to go because they're the real doctors. And so I didn't do medicine till the very end because I wanted to be like perfect student by then. So surgery was right before medicine, and I think that's why I chose medicine. I chose surgery.
Your rotation during third year.
My surgery rotation. And I was destroyed. My intern quit, so I was given the intern pager, which for those of you who don't know,
as a medical
student, as a third year, I was what we call scut monkey, or everything goes to the intern. So my pager was going off all the time. Plus, as a student, you have to go to clinic and go to the ORs and do all that.
And read and study and try to figure out how to do the operations, right?
So 4 a.m. I would wake up and I would cuss. I would wake up going, and then I'd go do what I had to do. And I had the meanest chief resident, and he was so mean to me, and he knew that life sucked for him because his intern, who's supposed to do all the work for him, left, and he had me. And I don't like to not please people. And I was on the chairman's service, and the reason why the program was very malignant was because of the chairman. But I felt like I was an integral part of the team. So when I left surgery, I did medicine. I was like, really? That's all you do?
Right.
There's so much more you can do with your day.
I know. You're like what? We're rounding it. So when you say malignant, because most viewers will not understand what that means in reference to a residency.
Correct.
And Elizabeth's probably like, she's talking about cancer, right?
Abusive.
I was like bad, horrible.
Yeah, people would cry. They would get fired.
Oh my God.
There were lawsuits
General
involved.
surgery
is no joke.
No joke. It is a rough residency.
So it's Grey's Anatomy on steroids.
110. I mean, we trained before there were work hours restrictions.
154 hours, 144-hour weeks, like crazy hours.
Wow.
I was not sleeping. I lost 20 pounds on my service, which my chairman said, you were doing great, Shirin, because you lost weight. If you don't gain or lose weight on my service, you're not working hard enough.
Oh my God.
So that was
what a blessing. It went down. Yeah. Me, I probably would be like binging.
I wasn't eating. But I felt like I was doing something. And so I went to surgery at UCLA, loved it. I loved every moment of it. My first job was at USC, the rival institution in Los Angeles. And my first patient was a mesh infection patient. And I fixed her and got 3 patients like her. And there was a post for the American Hernia Society meeting, which I'm like, there's a Hernia Society meeting? That's strange. So I sent my experience in handling mesh infections with, at that term, alloderm had just come out, which is a biologic thing that the plastic surgeons knew a lot about. And I got accepted. I showed up to the meeting, and I was like, wow, this is a very old person's meeting. But I met everyone whose names are on all these surgeries, like Schuldeis surgery, Dr. Schuldeis was there. Lichtenstein surgery, Dr. Lichtenstein was there.
Lichtenstein trained at Cedars.
Yes.
right?
Yeah.
He developed that operation at Cedars-Sinai.
At my hospital.
Yeah.
Yeah. So it was like the coolest
I think that
thing.
was back when Dr. Phillips was training.
It was, yeah. Yeah. Phillips trained at USC as well. So I was like, this is the coolest thing ever. And then the rest is history.
Wow. Do you see the mesh evolving into something else that is maybe not as causing like toxicity in the body?
I think because of the patients, industry that makes the mesh is getting the message. There's lawsuit after lawsuit. They need to get out of that environment.
Yeah, you even see it on TV.
Yeah. So there is a great interest to reduce mesh reaction, reduce mesh-related complications, and kind of move away from this overuse of mesh. Doesn't mean we're not going to use mesh, but what we know as mesh today is very different than the evolving kind of inventions of mesh that are less inflammatory, less overall synthetic, permanent synthetic, and hopefully better for the patients.
And you also are a badass because you don't only work with hernias, but even your specialty is complication with a hernia or a mesh, which is really, really interesting. And you don't expect this younger hernia doctor. I always think of a hernia doctor like an older man, you know.
I think I'm older than Dr. Brenner.
Well, you look amazing.
Don't
say that.
I'm willing to bet I am.
So, when you speak or write, like, and you're talking about the hernias, and you're in this meeting with these speakers, with these doctors, and you're telling them your theory on mesh illness.
Yeah.
How is that received?
Initially, it's hard to get the papers published. Well, what about this? What about that? How could you prove that it's the mesh? And it was mostly they weren't inviting me to talk about it. I was pushing my research out there, and then I was like talking about it, writing about it. We have forums online where we discuss things, and I'm very busy on those. And then now almost every meeting now, I'm put on some panel that talks about mesh, or I'm running the panel of discussion about mesh complications. It always includes mesh illness. So the meetings now are including it, which is really great to see.
Oh,
but
wow.
It's usually I'm almost always involved in those. Yeah.
Well, yeah, it's interesting because I just saw an ad the other day for what are they called when you sue a collective lawsuit?
The mass tort litigation.
Yeah, like they were asking
class action.
Yeah, class action suit against hernia mesh.
Yeah,
meshes.
Unfortunately, the law firms are also taking advantage of the patients.
Yes, I
the patients
agree.
are not winning, so to speak. The law firms are.
Right. There's never big money in any class action.
No.
No, but I mean it's a hot topic because.
But it is a driving force. It is
Yeah.
a driving force, and it's making it's forcing the surgeons to talk about it. Before we're like, yeah, we'll fix your hernia, and many surgeons didn't even tell them they were using mesh. It was kind of a given.
Right.
And now you're obliged to spend more time with the patient, describe mesh, non-mesh options, risks of mesh, which is a good thing because patients should be aware of what we're doing with them.
Yeah.
But yes, a lot of resistance.
Yeah. You're going through that.
The plastic surgeons, most of the plastic surgeons that I talk to don't think they don't say it to my face. But
Yeah.
They probably think I'm crazy.
Yeah.
But they don't see the patients. But
They think I'm crazy.
They just don't think it exists.
Yeah.
Like,
Correct.
oh, well, it must be all in their head, which is what I hear from every single patient, not just from their original plastic surgeon, but from their internist and their cardiologist.
Correct.
And, everyone thinks that they're making up these symptoms.
Correct. But I have rash pictures. You can't make up a rash.
Or pancreatitis.
Or pancreatitis. So the last paper we published, we actually put up pictures of before and after of rashes. And I do allergy testing as part of what I'm trying to learn. Like, can we pre-test some of these patients? But yeah, so the doctors think we're crazy because they
And the
haven't
patients
caught
love
up
you
yet, which is
guys.
okay. All I can do is continue educating. And then the lawyers are feeding so much negativity to the patients because there are a lot of patients that need mesh. And when I say mesh, it's like 100 different options. It's not just, quote, bad mesh. There's a lot of options. But the law firms are preying on these very vulnerable patients, getting them very afraid. There have been situations where patients are kind of forced to remove meshes that maybe they didn't need removed, to be part of some class action lawsuit. It's kind of bad. I wrote a paper, we called it #mesh. We looked at social media and the discussion about mesh, and we followed pelvic mesh, so the transvaginal meshes.
Right.
And it
Is that, I'm not a gynecologist, so I've never used pelvic mesh, but I'm assuming it was, I think, because I saw this actually, there was a special on Netflix.
Yes.
I think, is it polypropylene mesh or
They're all
some
polypropylene based,
version? Yeah.
correct. And
It's a disaster. I mean, it
disasters.
erode into the vaginal cavity, and you can't get it out.
Can't urinate, it erodes the urethra, the vagina.
And it's almost impossible to take out.
Very
sometimes.
difficult and very, unlike hernia mesh, very like it deforms you almost sometimes with the action of taking it out. To the point where FDA has now changed the classification of pelvic mesh for these urinary incontinence patients to high risk, which has not happened with hernia mesh yet. So we're curious, like maybe that's the future of hernia mesh. So let's look at the social media chatter and correlate that with the eventual FDA ruling. And we found that it's not only perfectly following the curve, and we're about 7 or 8 years behind, but it's actually worse with hernia mesh. It's actually a higher volume of patients involved, and the amount of negativity is worse. And we looked at the biggest social media generators of negative discussions about mesh. Every single one, except for I was also among the top social media users of the different keywords for mesh. But every single other person is being paid, or is actually belongs to a law firm. That is part of the class action. So they are driving a lot. They're really stirring it. Yeah.
So, which brings me to my next question for you is you just recently obtained a patent, right?
My 6th. Yeah.
Tell me, are these are all mesh patents?
Yes, they are.
And without going into too much detail, what are your patents? What's unique about your mesh patents? So
they're qualified as gender specific meshes for the groin. So inguinal hernia mesh. Right now, 80% of my practice is revisional surgery, and oftentimes I'm removing mesh. And so sometimes it's put in incorrectly by surgeons, but sometimes it's the mesh itself has a defect that is increasing the risk of complications. It gets stuck around a lot of the male kind of genitalia, the cord, the vas, the stuff that causes testicular pain and sexual dysfunction in males.
And nerves.
And nerves. Same in women. It causes a lot of chronic pelvic pain and sexual dysfunction in women. So it occurred to me that we treat men and women exactly the same, but the pelvises are very different.
Very.
And so maybe we should have different anatomically different meshes for men versus women.
Shape and orientation of the orifices on the mesh when you're putting it in for inguinal
is different.
I mean, on a woman you don't really even need that.
Correct.
Right? Yeah,
Correct.
Because the round ligament doesn't actually go through.
Correct.
There's no cord.
And we don't need mesh to stick to the bladder, to the nerves, to the spermatic cord. Everything goes down the testicle. Those are structures that don't need mesh stuck on it. So I revised current meshes so that those areas don't get eroded by mesh or affected by mesh.
Wow, that's amazing.
The material on those
whatever you want.
Is it still poly? It's just, so the patent is on the design,
yes,
not on the material.
Correct. The material can be the newest material that has the least amount of inflammation.
Right.
Yeah.
And so we're still trying to figure that out.
Correct.
What's causing, what causes, what doesn't cause. Now, when you have a patient with mesh implant illness, and you're taking it out, right?
Yes.
What what else are you taking out besides the mesh?
Just the mesh or any sutures or other implants that may be involved with it. But I take out 100% of the mesh. I don't leave any behind, even if that means like a vessel or something is nearby. Depending on where it is, sometimes you have to cut a nerve. It's not an important nerve. It's like a sensory nerve. But I don't take anything else out with it.
The reason I'm bringing this up is because with breast implants, there's a capsule around it. And with mesh,
I mean,
it's not quite the same because you kind of get like a peritoneal lining, right? That's the lining of the abdomen that covers it. But mesh has actually tissue ingrowth into it.
Yeah, very little tissue comes with it, very little.
But like with a pacemaker, with an artificial joint, you actually get a capsule around all of these foreign bodies.
That's a good point. I never seen a capsule.
Because the other sticking point in BII is how to manage the capsules.
It makes for beautiful Instagram pictures though when you guys take it out and it's like this. It's gorgeous,
right? like
perfectly spherical, crunchy.
It's kind of crazy.
That's the goal.
And I think
not always like that, but that's the goal.
And I think for the patients, it's like you're like, wow, because we don't think
it's a good
like
visual,
medical.
though, right?
Yeah, I never knew that there was a capsule around an implant. So.
But it does beg the question: like, are there patients with pacemakers who are experiencing the same thing, or other implanted devices? I mean, there's, insulin pumps and other implanted devices, and I think. The confounding factor is that some of these patients are so ill with whatever other medical problems that they have, especially people with pacemakers, right? Because they're generally older with other comorbid conditions, that it may not even raise a flag. It's probably not even a blip on their radar in terms of the symptoms that they're having, A. And B, like someone needs a pacemaker, you can't get rid of their pacemaker. I mean, you can, but...
there's
not
some old school ways of fixing the heart. Yes, so everything is a risk-benefit ratio. I think titanium and some of the metal is less reactive, but even those, when they remove it for whatever reason, and you send it to the pathologist, they'll say foreign body reaction, chronic inflammation.
Right.
All of these will be found on the pathology. So your body is reacting to it regardless of what it's made of.
Well, there was I made reference to a special that was on Netflix about medical devices.
Yeah.
I don't want to say the name of it, but
but it included
but it included
hips.
A cobalt-lined hip joint that was liquefying, and people were getting cobalt toxicity.
And a doctor figured that out.
He was an orthopedic surgeon. Yeah, because he had it himself, and then he got sick.
Yeah.
Oh, Grey's Anatomy did a whole episode on that.
Of course you watch Grey's Anatomy.
I do.
Oh my God.
Well, I don't. My husband does, and then I can't sleep. I have everything that they...
My daughter watches Grey's Anatomy.
And 60 Minutes had a special on the pelvic mesh.
Wow.
Yeah.
Well, we're unfortunately going to have to wrap up the show. Quick. I know.
Where's part 2?
Well, we need to have you come back in for part 2.
That would be
especially after you knew... patents that
if I get
that would be amazing. So why don't you tell our listeners, especially those of you who have hernias, where they can find you, your social media, all of it.
So I'm the Hernia Doc. If you go to Twitter or Instagram, I'm at Hernia Doc. I do have my own website. I own the Beverly Hills Hernia Center. So if you go to beverlyhillsherniacenter.com, you can find me there. Something that I started back in 2013 and is like really grown is a free patient discussion forum. Anyone who wants to go on it, we answer all your questions. It's called Hernia Talk, and you can find that at herniatalk.com. And that's what you're on, yes, is
and
the live version.
And sometimes you go live. Yeah, right,
yeah.
live.
Wasn't it a Facebook Live? Hernia Talk?
So it's we call it Hernia Talk Live. It's basically an offshoot of the discussion forum, where I invite reputable doctors that I trust in different specialties and you to talk about hernia-related topics. And we talk to, basically national and international specialists. And
with live Q&A too, right?
Yeah, so you can find that on herniatalk.com. My Facebook page also has that. And I have a YouTube channel that has all of the Hernia Talk Lives. We're on episode 103 now.
Oh, wow.
Yeah.
Well,
So
thank
we
you
got,
so
we got, We have
much.
some catching up to do.
Yes, we do. A lot of catching up. Thank you so much for joining us.
Thank you.
And we just have
Thanks
to get
for
a
coming.
shot of her top because it's so cute. Can we say Beverly Hills Hernia Center?
See?
One of her patients made that. And
My
got talent.
patient
She has
blinked
talented
this whole
patients.
thing.
that's how much I love her.
Is that like your new logo now?
So H has been my logo. I own the letter H. So yeah.
Okay,
That's
well,
been my
thank
logo.
you so
Thanks for coming
much.
in.
Thanks.
And we'll get a part 2 coming up soon.
Yeah, so much to talk about.
Yeah.
Thank you.
All right. Take care, guys.
Thanks for listening to Beyond the OR with Dr. B. Make sure you subscribe so you don't miss any future episodes. In the meantime, connect with Dr. B on Instagram, Twitter, and TikTok at Kevin Brenner MD and KevinBrennerMD.com. Until next time.